Coming up on Mayo Clinic Q&A.
I believe any diabetic patient deserve a chance to be educated about pancreas transplant and maybe evaluated. These type of patients that they only have diabetes that are not been controlled, those are the best candidate for a pancreas transplant alone.
Diabetes occurs when the pancreas doesn't produce enough insulin or the body is resistant to insulin. For those with severe diabetes, a pancreas transplant may be an option to bring life back to normal.
The idea of a pancreas transplant actually is to cure diabetes. I like to call the pancreas transplant or the pancreas as an organ is an organic pump. The mechanical pump does not cure, it'll control. The organic pump, which is the pancreas transplant, it does cure.
Welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. Today we are going to talk about an exciting treatment for diabetes. Diabetes is a lifelong chronic disease with the potential for significant complications, but major advances have been made in its treatment over the last decades. Despite this, a number of people with diabetes still struggle with the disease. To restore normal insulin production and improve blood sugar control, pancreas transplantation may be a good option for some patients. Joining us to discuss this today is Mayo Clinic nephrologist, Dr. Tambi Jarmi. Thanks for being here today, Dr. Jarmi.
Absolutely, it's my pleasure.
Well, before we get started, would you just remind our listeners what is diabetes? And there are type 1 and type 2. What's the difference?
Correct. Diabetes is an abnormality in consuming or metabolizing their blood glucose. So diabetic patients, they have a hard time adjusting their blood sugar to the level that their cells needed. And it could be a result of a deficiency in the production of the insulin, which comes from the pancreas, the organ that is responsible to produce the insulin to control the diabetes, or it could be a result of a resistance to that insulin. So when we have more of a resistance, it's called type 2. If we have a production problem, it's called type 1. That's the main difference between the two, and both of them will result in an abnormal blood sugar in these patient population.
That's interesting, Tambi. So in the second type 2 diabetes, you essentially have what you need, you just can't use it.
Correct. That's absolutely right. You do have what you need. It's you can't use it, and maybe you don't have enough of what you need, but
Okay.
the production process is relatively intact.
What in the world is the pancreas? Where is it? And what does it mean to have a transplant?
So the pancreas, it is in the mid-abdomen or in the middle of the abdomen, and it's in the back, close to the spine. It's attached to the small bowel. It comes right after the stomach, and it's attached to the small bowel. And to have a pancreas transplant, it's a replacement of the endocrine function, what we call it. It's not a replacement to the digestive function of the pancreas, because the pancreas have two major functions. One is to control the blood sugar in the bloodstream, and one also to provide the appropriate digestive enzymes to help us digesting the food. So that's why it's connected to the small bowel. What it means to have a pancreas transplant is not to take the old one out and put a new one. Actually, the old one stays in. The surgery is far away from the old pancreas, and the old pancreas continue to function and help the digestive system. So that functionality has not or will not be changed or altered by the pancreas transplant. The pancreas, the organ that's been transplanted will mainly be for diabetic controls or blood sugar treatments. It will not provide any digestive benefit to the patients.
So are you actually taking a pancreas from someone else who is deceased and transplanting it in as we might with another organ?
Correct. So in the United States and in the world, a living pancreas transplant is not something is popular. So mainly it's a deceased pancreas transplant. So we take the organ from a deceased donors and the organ comes with a piece actually of the small bowel of the donor, and that get attached to the small bowel of the recipient in the front part of the abdomen. And also the organ will be connected in terms of the blood flow. The pancreas should receive a blood flow from a small anastomosis with the patient's circulatory system, and it drains also through the venous system. Technically, you will not be able to feel it, even though I'm saying it's in the front of the abdomen, but it's still inside the abdomen. But in front means it's away from the native organ. You will not be able to feel it or touch it or say, hey, I have a pancreas transplant. No, that's not the case. It'll stay inside the abdomen, and hopefully it will cure the diabetes.
Tambi, you mentioned both type 1 and type 2 diabetes. Are transplants appropriate for both types?
The idea of a pancreas transplant actually is to cure diabetes. So far we do have so much advancement, I think, into the diabetic care, all the technology, all the pump, the glucose monitor, all these systems. And I like to call the pancreas transplant, or the pancreas as an organ, is an organic pump. So rather than have a mechanical pump that actually does a great job, but we all need to remember that the mechanical pump does not cure, it'll control.
Mm-hmm.
The organic pump, which is the pancreas transplant, it does cure. So my patients a lot of time they will have a really hard time understand the concept that they're not diabetic anymore. And we have really hard time with some of them to get them to stop checking their blood sugar, because they've been suffering from this disease for a long time, and they still used to check their blood sugar with a finger. And we tell them, you're not diabetic. So in 2000, if I remember correctly, 18 or 19, around that time, the UNOS, which the organization that regulates who is candidate and who is not, or give recommendations in the United States for organ transplant, took that terms from the candidacy recommendation, meaning type 1 and type 2. So there is no difference when it comes to transplant between type 1 and type 2. The only major factor is the patient using insulin? If so, then why don't we use an organic pump rather than a mechanical pump? So that's the main issue so far.
That's really interesting to me. I'm not sure that it quite makes sense to me. For type 1 diabetes, I can think through, if you don't have enough insulin, you have a new pump that's making insulin. However, if you are a type 2 diabetic and you have insulin, but you just can't use it, why does making more insulin improve that?
Because in a type 2 patients, when they get too difficult to control, they end up on insulin. So they have some, they need more.
Okay.
So that more could be provided by the organic pump. They still, remember, they still have their old pancreas that's still there, still providing some, and they get an additional. In the type 1, they don't have any, so they get a fresh start with a new organ.
That makes perfect sense. Thank you for the explanation. How do you decide if someone is a candidate for a transplant?
This is actually a very important question, because I believe any diabetic patient deserves a chance to be educated about pancreas transplant and maybe evaluated. Now, our target is to cure diabetes and ultimately minimize the side effects or the downstream effect of diabetes. So the way we decide who is a candidate or not, if the patient is doing absolutely great with their diabetes, meaning hemoglobin A1C is close to normal, on target, they don't get ups and downs on the blood sugar, they don't get hospitalized because of the ups and downs on the blood sugar, their social support is not also suffering because of their diabetes, meaning a mom that does not need to drive the child all around because the child has diabetes and they're afraid that they could pass out from high or low. meaning a husband cannot leave his wife at home because he's afraid she's going to go low or high. So these patients need to be evaluated versus the one that's doing great. They could stay where they are. But the one that's really suffering from controlling the diabetes, I think they deserve a chance to be evaluated and they should be a candidate.
In a moment, we're going to talk about the different types of pancreas transplant. But can children have transplants as well as adults? Is there an age range when they're provided?
Technically, yes, they can, but usually it's an adult
Okay.
procedure more than children, not for any reason except a compliance. So transplant is a major process and they have to take medications after the transplant forever. And there is a significant risk of skipping the medicines. And we all know at age 18, maybe, I don't know what age, until you get really uh, following instructions. So we don't want to risk that the child, you know, at age 18 do a transplant, they feel great, they think they're doing great, and they start skipping the medicines. That's the scary part of it. So we wait a little bit until they really like involved in their
Sure.
life, daily activities, and responsible.
Right. So they can take responsibility for
Correct.
the decision, essentially. Well,
Correct.
tell us about the 3 types of pancreas transplants and why each of them might be used.
So there are different ways of dividing the pancreas transplant. The main one is the pancreas transplant alone, what we call it, is the pancreas will be used for an early diabetic patients. And that's what we hope for, that a diabetic patient's only struggling with the diabetes control at this point, but they have not yet developed significant other end organ damage. They don't have advanced kidney disease, they don't have advanced heart disease or advanced retinopathy or neuropathy or losing one of their legs because of the vascular injury because of the diabetes. So these type of patients that they only have diabetes that are not been controlled, those are the best time or the best candidate for a pancreas transplant alone. Now, the combined pancreas and kidney is kidney disease is #1 complications of diabetes.
Which is why I'm talking to a nephrologist today, right? Who
Correct.
specialize in kidneys.
Correct. So majority of the pancreas transplant in this country or in the world are done as a combined kidney pancreas. Somehow it's unfortunate too. That means we left the diabetes for a long time to damage the kidney, and now we have to replace both organs. The pancreas after kidney, or also we do pancreas after other solid organ transplant. Those are the patients that received the kidney transplant. They were young, they received it at age 25 for whatever reason. And then down in the road, they developed type 2 diabetes, or they had a pancreatic injury that caused them to have diabetes. Then we could do a pancreas after the solid organ transplant. So it could be done in multiple ways, but at the end, it does the same job. It cures the diabetes.
It's amazing. Tell us a little bit more about how a transplant is performed.
So in general, what we do in the process is we detect or we get a chance to evaluate diabetic patients. And obviously, the evaluation process is extensive. We need to make sure that the diabetic, whoever is being evaluated, is completely checked and ready to go through a short period of time, which is the transplant surgery itself, and a long period of time that we hope that they outlive the organ, meaning we hope that they have a great life to come. So we examine them sort of head to toe to make it simple and make sure they're good to go. And then they will be listed. The good news, the wait time for a pancreas transplant is it's actually a lot shorter than kidney transplant. It average in the United States about 1 year to wait for an organ versus 6 years for a kidney.
Wow, that
Yes.
long.
Yes, sometimes I have been involved in patients that we transplant them within month. So it's a very quick, and they just have to wait. Once we call them, they show up in the transplant center, they get transplanted. The length of stay is about 6 days here in our transplant center. And after that, their life has changed. They totally healthy, non-diabetic, they could resume their lives. They could, disability from diabetes will go away. They go back to society as a productive persons, and a new chapter of their life will start.
I would think that has to be an incredibly life-changing, even mentally,
It is
challenge for people, because you've been told maybe from the time you were a child that you need to count your carbohydrates, you need to watch your
correct.
sugar intake in particular, things like that. And then to be able to not have to think quite so tightly about those things, that has to be quite a lifestyle change.
Correct. And I wish we have a chance to share our patients' experience with the diabetic patients, because it is life changing. You cannot imagine how happy the patients are with a successful transplant. We have patients that could have a normal social life. We had a patient that was able to get pregnant after the transplant and have a normal pregnancy without checking her blood sugar,
Hmm.
and a healthy child. So it is, and it gets to the simple things in life too. I have patients tells me, well, now I could eat ice cream and I don't have to worry about it. I mean, these things maybe for non-diabetic patients are normal things that we do every day, but diabetic patients really suffer during their course of disease. And for little things, I mean, we eat
Yes.
ice cream and we don't care too much.
Right. Or to be able to go to a birthday and have a slice of someone's birthday cake.
Correct. And you don't have to worry about it and count how many calories you did and what extra dose of insulin you need to give yourself. That's all gone. And they extremely happy after the successful transplant.
Are there any side effects of having a transplant?
Of course, any surgery, there are I will put it in two categories: an immediate side effects and a long-term side effects. The immediate side effects, it's related to the surgical procedure itself. Patients could, with a minimum, very small percentage, they could get a complication from surgery in terms of a wound infection or bleeding. In the long run, after the transplant, the main side effects are the side effects related to medications. There is a slight increase of a long-term cancer because of the medications, and that's something get a little bit over looked at when patients try to look up the information and they get scared of it, but it's actually less than 4% increased risk. It's not like you're talking about 50% increased risk. And once you're a transplant patient, you are attached to a transplant center for the rest of your life. And we make sure that every health requirement is done. So meaning we get them to have their annual checkup, their annual exams, their annual requirements, and anything that we could catch early, I tell the patients, we could fix and cure, even if it's cancer.
Well, what you said about you're attached to the transplant center for life, that's sort of a mutual relationship. But how do patients decide what should they look for when they're looking to pursue a pancreas transplant?
I think that's very important, especially with the pancreas transplant, because not too many centers in the country now they doing this. There's about 126 transplant centers in the United States, and I think less than 30 perform pancreas transplant,
Oh,
if I'm
wow.
not mistaken. So it's important to find which center that does the pancreas transplant. Transplant center does not mean they do pancreas transplant. They have to check for that. And these data is a public data. To me, I think the most important part when you look at a transplant center is to find a center that has a team approach and consider you as a family member more than a patient. The patients actually will be surprised when they go to a transplant center because they'll have a pre-transplant nurse coordinator and post-transplant life nurse coordinator. They get to know them extremely well on a personal level. And that's what's important, that you have a team approach and accessible personnel in that center that could answer your concerns and answer your questions in timely fashion. I always tell everybody I know that we're proud that we take ownership of what we do. Those patients are our patients. They invested in these organs. We invested in these organs. We obligated for the donor family to make sure that these organs that have been donated survive. And we cannot, and that's the most important fact, that in any transplant center that follow these patients and cannot let their patients go anywhere else.
Yeah, this strikes me as one of those things that you would want to go somewhere where this was performed regularly, where it was a regular part of practice, because it's a precious gift that you're being given, but it's also a major surgical procedure, and there's care before and after. So I could see that you'd want a center that not only had a team, but good experience.
Yes, absolutely. And unfortunately, only few centers. So the geographic distribution of the centers in the country play a role. So patients, they need to know which center that do pancreas transplant and close to where they live, because it's, as I said, it's a lifelong relation. They always going to go visit at least once a year that center and have a complete checkup done.
Mm-hmm. Well, that's very interesting. Anything else to share with us today, Tambi?
I just hope that we have more access to diabetic patients. As you mentioned earlier, that I'm a nephrologist. I'm not a diabetic doctor. So we need to get this amazing opportunity or health advantage to the patient's population that in need. And I hope we will in the future will be able to maybe transplant everybody that needs it. I hope so. I don't know if we could do that, but at least the patient that in emergent or urgent need for a pancreas transplant, I hope we reach them out and they reach to us and we'll get things done.
And I know that I signed up to be an organ donor after having discussions about the need for organ donations, and what a challenging time for families when they are in a situation where their loved one is deceased. But to see them live on in many others is very gratifying as well.
You're absolutely right. There is a fact that every potential deceased donor could save 7 lives.
Oh, wow.
So it's not 1 or 2, it's 7 lives. So it's an amazing thing to be an organ donor, and it does really change patients' life. It does. We see it every day.
Thank you for being here and sharing with us today, Tambi. Any last words for our listeners?
No, I hope the best for everyone. And organ transplantation is not like what used to be 50 years ago. The medications we have, the advancement we have will get people back to normal life, and they will be back productive in their society. And I don't think it's as sounds big deal as it is. It's not. It's a very piece of cake.
And then you can have a piece of cake.
And you can have a piece of cake. Maybe not that big piece of cake, but
a little piece of cake.
Yes.
Thank you, Tambi, for being here to share with us today.
Absolutely. Thank you so much.
Our thanks to Dr. Tambi Jarmi, nephrologist at the Mayo Clinic, for being here to discuss pancreas transplants for diabetes with us. I hope that you learned something. I know that I did. We wish each of you a very wonderful day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.